record button is pressed.
So now we're being recorded as we speak.
Yes.
Pause it.
It just, once this is warming up, it's recording. Okay. Okay, I want to thank everybody for coming. This is our first Zoom meeting. And we have Kelly, the wonderful Kelly here from the Diagnostic Clinic. Just so you guys are aware, we are recording so people can access this video at a later time. Yes, we ask everybody to keep the privacy, but know that the confidentiality does not stick with Zoom. So please, if you are talking about someone, just be aware of that. And I'll let Kelly take it away.
Thanks, Kim. So yeah, my name is Kelly Ruskovich. I'm the clinic lead for the FASD Diagnostic Clinic at Neo Kids, Pediatric ACU, Health Sciences North. I've been in this role for about 5 years, maybe a little bit more now. And so we're going to talk about what FASD is and specifically the diagnostic process. Just if you have a child that's going through this or somebody who would benefit from an assessment, this is just a little bit of information for you. So just very briefly, maybe a recap for a lot of people on the format. What is FASD? And so FASD, of course, is a group of effects that occurs when a fetus is exposed to alcohol in utero. It's present across all social, ethnic, cultural backgrounds. It's present worldwide. Most recent statistics say that in Canada, it's present in about 4% of the population. And that could be lower or higher in some regions. So FASD is diffuse organic brain damage or brain differences, which we'll talk about a little bit later. And it's the leading cause of developmental disability or intellectual disability worldwide. Alcohol can also cause damage to not only the brain, but any other organ in the body. And so it can cause organ or congenital anomalies. We don't really assess for those here, but we do a medical component and we may find some anomalies in that medical exam. FASD is unpredictable in its developmental outcomes due to a large number of factors, some of which is environment and some of which is just sort of the brain differences themselves and how those interact with the environment. FASD impacts an individual across their lifespan. It's not a disease of childhood. It's not a disorder of childhood. It's a disorder that impacts an individual across their lifespan. It's not curable, but because it's a physical disability, but individuals who have early diagnosis and get early interventions have better outcomes. And so that's what we endeavor to do here at the Diagnostic Clinic is identify and assess and diagnose early so that interventions can be put in place. FASD, the public health message, will tell you that FASD is preventable. And on the surface of that, we could say that's true if a woman does not drink alcohol during her pregnancy. Then, sorry, there's an assessment happening right behind me, so I don't want to be too loud. So we were talking about prevention. So it is on the surface, it's true if a woman doesn't drink alcohol during her pregnancy, then the fetus is not exposed to alcohol and there's absolutely no chance that a child would have FASD. However, the reasons why women drink, which we'll review in a minute, sometimes they're simple, sometimes they're complicated, and that is not so easily preventable. And so we really do need to keep that in mind when we're working with women who may have used alcohol during their pregnancy and be very compassionate because there's a lot of reasons why women drink during their pregnancy. Okay, so just a little bit of FASD math so that we can put things together over the course of this presentation. Stats Canada says year after year that about 75% of all women who are drinking age drink alcohol in Canada. So it's pretty commonplace. We know also year to year globally about 50% of all pregnancies are not planned, right? And then sometimes we don't know we're pregnant right when we're pregnant. It might be week 3, week 4, week 5, week 6, month 2, month 3, month 4. If we're not planning a pregnancy, then we might not know we're pregnant until we're a little bit further along. But we know that prenatal alcohol exposure can impact the growing fetus at about week 3. And the demographic, all these are stats, we'll put them together in a minute. The demographic for the growing, at growing risk for a child with FASD is a woman who is Caucasian, in her 30s, has a post-secondary education, is single, and earns $50,000 or so a year. And that's because she has lifestyle habits that would put that fetus at risk if she's pregnant unknowingly. So what we can see is that women drink. 75% of all Canadian women drink. At least half of all pregnancies are unplanned. If you have an unplanned pregnancy, you may not know you're pregnant until further along in the pregnancy. And so we're what I'm trying to impress is that a lot of alcohol exposure can be unintentional. And this is the most common scenario we see here at the diagnostic clinic, is that women drink before they know that they're pregnant. After they realize they're pregnant, they either stop drinking or try to reduce harm. And so this sort of sets us up, further to understand that drinking is commonplace. It's largely socially acceptable. So why do women drink alcohol? It's normalized in our environment. It's normalized in our society. It's socially acceptable. Most women of drinking age drink alcohol legally. It's legal. And so women of different ages drink alcohol to different extents. We know that some younger women, particularly those that are university or college age, may engage in more high-risk drinking habits, binge drinking, weekend binge drinking, parties, so on and so forth. But all of that is largely to date socially acceptable and normal. And so, I'll just go back. Here at the clinic, we really take a lot of steps and a lot of effort to understand why a woman who presents with a child for assessment may have used alcohol during the pregnancy, accept that, allow her to be relieved of the guilt of that. And that is sort of our working pretense here. So what factors impact a woman's likelihood to drink alcohol during the pregnancy? So number one is an unplanned pregnancy. She doesn't know she's pregnant. She can't modify her lifestyle plans or habits if she has an unplanned pregnancy. So that is certainly the first and foremost risk factor. A previous history of alcohol consumption, not abuse, just use, social use, perhaps social use that would put a fetus at risk. A family background of alcohol use. And, so that's, drinking a glass of wine with dinner, sharing that wine in some cultures with children, a little bit of wine at dinner. So any alcohol use in the environment would place a woman at risk for drinking alcohol during pregnancy. Now, certainly, the more alcohol consumption, the more possible risk. And so if somebody has a history of inpatient treatment for alcohol abuse, or grew up in an environment where alcohol was abused, there's a higher risk that she may use alcohol to a degree that would put the fetus at risk. If the woman has any mental health problems, previous birth of a child with FASD, if she is in an environment where there's physical, emotional, or sexual abuse, if there's low income, limited access to health care, limited awareness of FASD or the effects of alcohol on the fetus. And I have to tell you that even now, after many of us on this committee have worked years in FASD, and one of our shared goals is providing education about FASD, but at that same time, there still is a lack of awareness about the effects of alcohol on a growing fetus. Not just in the lay population, but sometimes even in the healthcare population. And sort of that's our goal, is to raise the awareness, and that's what FASD Day is all about, is talking about it again and raising the awareness. And so if you don't know what alcohol can do to a fetus, and you're not aware of the risks, then you're at a higher likelihood to use alcohol during your pregnancy. If you haven't received adequate prenatal care, you're at a higher risk as well, because it's that prenatal care, that connection with your healthcare providers, your primary healthcare provider, your family doctor, your gynecologist, OBGYN, your midwife, who are responsible for, asking you those questions, giving you the information, and helping you, if you're using alcohol, reduce harm. And so if you haven't had access to prenatal care, then you're not having access to that engagement and that intervention. Social isolation, of course, high exposure to high levels of stress. These all put a woman at a higher risk of using alcohol during her pregnancy. So let's talk a little bit about alcohol thresholds. What do we consider enough alcohol use to warrant FASD assessment? The caveat being the child has to be presenting with significant or some difficulties, right? So 7 standard drinks per week. So that's a drink a day, or 2 drinks on Tuesday, 2 drinks on Thursday, and 3 drinks on Saturday. No binge episode by definition, but 7 standard drinks inside 1 week during a pregnancy would cause enough concern if the child is experiencing difficulties for us to say, okay, let's assess this child. Or 2 binge episodes during an entire pregnancy. So a binge episode, by our definition, is 4 drinks in 1 sitting. And if that happened 2 times in an entire 9 months, and the child is experiencing difficulties, that would be sufficient for us to say we would assess this child. So this is a threshold of exposure that we're looking at. And as you can see, it's very low. And so, 2 binge episodes, that could be a family reunion weekend over the summer. That could be Frosh Week, the youth getting together, pre-COVID, of course, but youth getting together, and celebrating the start of the school year. It could be, the week between Christmas and New Year's. And so there's a lot of opportunities that women have to drink alcohol socially that would put their child at risk of having FASD. Now, this is not to scare you. It's just to educate you. Because I think I'm hoping that there's greater FASD awareness in 2020 than there was in 2000, for example. But I'm not too sure if people understand how low the threshold is, or how little alcohol it would need to impact the growing fetus. So that brings us to the question, why is alcohol so dangerous? And I get this question a lot. Well, I get phone calls, my child was exposed to drugs during pregnancy. Are they eligible for assessment? No. And you have to appreciate that research on the effects of drugs or alcohol during pregnancy is very difficult to come by, and we can only do it after the fact. And if a woman has substance abuse issues and is using alcohol and other drugs, it's very difficult to tease out, well, what damage did, this drug do, or what damage did that drug do? What we do know from laboratory testing is that alcohol specifically is what's called a teratogen. And so a teratogen actually changes the way cells grow. It can cause cell death. And so a teratogen is any agent or factor that causes malformation of an embryo or a fetus. And the malformation that we're looking at with FASD is mostly at a cellular level. And there's a lot of teratogens in our environment, and it's not just alcohol. So excessive heat can be a teratogen, radiation, certain medications, systemic infections, they can all impact the growing fetus. But we do know that alcohol is part of this group. It's a very dangerous group of substances that actually alters the growth of the fetus. And so what can it do? So alcohol causes cell death. It can alter the way the cell is structured. It can damage any organ, really, in the body or the brain. It can reduce the myelin sheath on the nerves. that helps the conductivity, that helps our brain process different information. It can reduce the amount of interconnections we have in the brain, interfere with brain chemistry. And so, you know, the brain is a very sensitive organ. And at different times during the pregnancy, throughout the whole pregnancy, it's vulnerable to exposure to alcohol. And certainly, you know, the potential damage is correlated with the amount of alcohol one may consume. And that's what we're assessing here. And so we can have differences to gross brain structure, and that's one of the things that we measure. We measure the size of the child's head, which really gives us a good reading of the size of the child's brain. And so what we do see in some cases is a child's brain is overall smaller than expected. It can cause localized damage. You may have some parts of the brain more underdeveloped than others. You may have some parts of the brain structure that are formatted very differently or maybe missing. But most of the damage that we see is at a microscopic level. And so this is what we're assessing. And you can't see that. And so a lot of people ask us, for example, we don't do MRIs or CAT scans because, you know, what we've been told is about 15% of individuals FASD will have changes on these images. But that still doesn't tell us how the brain is processing information, because at the microscopic level, if we have disorganization, we have changes in brain processing. So fetal alcohol spectrum disorder is a spectrum disorder, more recently understood, where we can have severe impairment and we can have more isolated effects, more isolated cognitive abnormalities that impact the person's functioning overall. So this is my primer for the children when I try to explain how alcohol impacts the brain. And, you know, I like to keep it simple. So essentially, you know, the brain cells all grow in the brain stem. So the brain stem is at the back of our head, and the brain grows from bottom to top, from inside to out. And all of the cells that comprise the whole of the brain originate or born in the brain stem, and then they migrate. Okay, so they have a pathway. So the brain cells that are responsible for language go to the language center of the brain. The brain cells that are responsible for motor coordination go to the motor cortex. The brain cells that are responsible for memory go to the memory part of the brain, so on and so forth. And if alcohol disrupts that migration, which is one of the main causes of alcohol exposure, then those brain cells don't organize themselves in a nice, neat, orderly fashion, right? So the brain has now organized itself a little bit differently because the alcohol exposure has disrupted that cell migration. And so if a brain has organized itself differently, it's very understandable to expect that that brain processes information differently. And that's what we're trying to get to the heart of here at the diagnostic clinic. How is that brain processing different sorts of information? This is just a little cross-section slide of brain cells. And when I talk about that organization, we see the slide on the left, the normal brain organized very neatly. And so when it processes information, we can expect it to go through predictable pathways to process that information, and that when you're processing that information, you're processing relatively the same as everybody else your age. The slide on the right is an individual that's been brain that's been impacted by alcohol exposure, and you can see it's organized itself very, very differently. And so this brain has organized itself very differently and is going to process information differently. So brain differences equal processing differences. FASD measures brain processing, and that's what we do here. And so what we're measuring are primary disabilities. So that's any brain function that originates, any function that originates from the brain, okay? So behavior and learning dysfunctions that are the outcome of brain damage, that are caused by a change of structure, chemistry, or function of the central nervous system, or function of the brain. That's a primary disability, and that's what we're measuring here at the clinic. FASD also has, oh, sorry, got ahead of myself there. And so when I talk about central nervous system, we're really talking about the brain processing. And so we measure brain processing, and we try to determine if there's abnormalities that lead to cognitive impairments, behavioral or learning difficulties, and difficulties with adaptive skills problems, or adaptive skills. So how you function every day in different environments, at school, at home, in the community. We also measure for facial features. And the facial feature measurement doesn't mean anything about how the brain is processing information. It just means that that fetus was exposed to alcohol during a very narrow time frame, depending on the research you read, between about day 15 and 21. And while it doesn't tell us anything about how the brain is processing information, what it does tell us is that this fetus for certain was exposed to alcohol, because these three features are so specific to alcohol exposure. And so what we're looking at are smaller eye openings, a thin, what we call a vermilion border or thin upper lip, and then the two lines between the nose and the upper lip are called the philtrum, and that is also flatter as well. So we're looking at small eye openings, a thin upper lip, and a flat philtrum. This becomes significant when we have difficulty establishing prenatal alcohol exposure or confirming prenatal alcohol exposure by history. And some of the children that we assess aren't with their original family. They're not with their mom. They may be in foster care. They may be adopted, or they may have lost connection somehow with their family of origin. And so sometimes we're faced with a situation where there's suspected alcohol exposure, but we can't really confirm it. And so some of the times we'll bring that child in to do facial photography to see if they have these three distinct facial features. And if they do, then we can actually confirm alcohol exposure by the existence of those facial features. And it used to be diagnostically significant, but in a recent change in our diagnostic guidelines since about 2015, 2016, it's significant because it tells us there's alcohol exposure, but it doesn't tell us anything about brain processing, but we still do measure it. So primary disabilities are the result of how the brain has organized itself differently. They may be behavioral difficulties, learning difficulties, difficulties with emotional regulation, so on and so forth. But individuals with FASD also are very susceptible to what we call secondary disabilities. So these aren't things that you're born with, but they happen over time. And I say they happen because of interactions between the primary disabilities, the difficulties a child is experiencing, and environmental expectations, right? And so if we have a child with FASD that goes undiagnosed for elementary school, for high school, for young adulthood, they're very highly likely to experience a lot of these secondary disabilities, which we'll talk about in a moment, because they're constantly butting up against expectations they can't meet because of their brain differences. And if you constantly butt up against expectations you can't meet, and that there's a cycle that happens that puts you at risk for a whole host of things. 90% of individuals with FASD will experience mental health problems in their lifetime. Disrupted school experience. If school is not a happy place, if it's not a positive place to be, children with FASD, youth with FASD are not going to stay in school. Because of brain processing differences, social skills differences, certain vulnerabilities, they have a really high likelihood that they may become in trouble with the law, unwittingly often. And so they're at high risk of incarceration. And I think that, we find a lot of people with FASD, a disproportionate number, of individuals who are incarcerated that do have FASD. A lot of individuals with FASD approaching puberty display inappropriate sexual behavior, sexual awareness, sexual boundaries are an extension of social boundaries and social skills. And if a child hasn't been able to learn these very important social skills as a child, and as they're approaching adolescence, they're not going to understand these boundaries either. And so they're at high risk of getting themselves into trouble in this way. They also have a really high rate of alcohol and drug problems. They're often, need to live with somebody to live successfully. So they need, supportive housing that really is not, doesn't exist. And so they're really at high risk of transient and homelessness and employment problems. And so these are, it's difficult enough having brain differences, having FASD. And, diagnosed early, we can help place, or we can, as a community, working with this individual, we can help put in place services and supports that will help prevent these secondary disabilities. And so that's our aim. So let's talk a little bit about assessment. How am I doing? Okay. And so when we bring somebody in for assessment, we bring them in for 3 days. And over those 3 days, they are assessed by our multidisciplinary team. The psychosocial assessment happens beforehand, and I do that as a clinic lead and social worker. And I try to understand the child as best as we can, speaking to caregivers, collateral sources, reading any reports that have been done about a child. And so I create a report, which I share with the team so that before they meet the child, they can know the child about as well as they can know the child. And once they come to Health Sciences North and come for 3 days, they'll undergo medical photography, medical assessment. They'll be seen by psychologists, speech and language pathologist, and occupational therapist. Over those 3 days, we're assessing 10 major brain processing domains. And there's a list of them on the screen, and I'm not going to read them. What we're looking for when we're assessing those 10 major processing domains is how is that child processing different sorts of information relative to their peers, okay? And so we give them a variety of tasks to do so we can help measure how they're processing memory information, attention information, how they're problem solving using words, using images, so on and so forth. The benefit of the assessment is the assessment itself. It's probably one of the most comprehensive assessments a child can undergo in their lifetime. So regardless of diagnostic outcome, the benefit is the comprehensiveness of the assessment. What we need to see for diagnosis of FASD, is across those 10 brain domains, at least 3 areas of what we call severe impairment, okay? Or when I'm speaking to youth and children, significant differences. So significant differences between the way they're processing certain sorts of information and other kids their age are processing that same type of information. So it's very specific. So if we have 3 or more areas of what we call significant differences or severe impairment across those 10 brain domains, knowing that the child was exposed to alcohol prenatally, then they would meet criteria for diagnosis of FASD, either with the facial features, if we have all 3 facial features, or without the facial features. And by far the most common diagnosis is without facial features because so few of the children or individuals with FASD will have all 3 facial features. So we already know that the benefit of the assessment is the assessment itself. There may be a diagnosis of FASD. We may rule out FASD. So if a child doesn't have any severe impairments or nothing as severe as it needs to be for a diagnosis of FASD, and we'll talk about that in a minute. And then we would rule out FASD. The other outcome of an assessment might be an at-risk designation. It's not a diagnosis. And that's when we have we don't have 3 distinct areas of impairment, but we may have 1 or 2, but we also know that maybe the child was too young for a full assessment, or the child couldn't, for some reason, finish the whole assessment. And that may be because they put the brakes on and they said, I'm done for the day or I'm done for the week. But we try to get as much as we can, but we may not be able to get everything, but we're still concerned. We will designate the child at risk. The significance of that is we really, really, really want schools and caregivers and individuals working with this child to take a step back and say, okay, to treat them like they have FASD, to give them the interventions and support that you would give a child with FASD, that you would give a child with a brain injury. To step back and say, the behavior I'm seeing, the learning problems I'm seeing are not because a child is being difficult. It's not because a child is behavioral. It's because a child has a brain-based injury. And so if we designate a child at risk, we will reassess the child at a later date. And kind of our cutoff is at least after age 8. So if we see a child at 5 and they get an at-risk designation, we have the assessment, we understand them as best as we can understand them at age 5. We have recommendations, we ask the school, we ask caregivers, or we ask community partners to treat the child like they have FASD and give them those services and supports, and then we'll bring them back and reassess them, at which time we go through the whole process again, and there's still a likelihood that they may have FASD or we may rule out FASD. But in the intervening time, we've tried to give them the benefit of the services and supports. And so those are the diagnostic outcomes. And so what is a severe impairment? And I get this a lot. And so it's, when we're looking at this, it's called the Gatian curve. In the middle is average, okay? That's at the 50th percentile. So it right smack dab in the middle. If I'm processing information like most people my age, I'm gonna score at the 50th percentile. If I'm severely impaired in any particular brain domain, I'm going to score at the 3rd percentile. And so when we're looking at scores, and because we score all of these little tasks that we give a child, and that's how we measure how they're processing in a certain area. So if we get, if a particular brain domain is scored at the 3rd percentile, for example, and I often tell people, I think my memory is a little bit impaired sometimes, I have to write everything down. But if my memory scores out at the 3rd percentile and you put 100 people exactly my age in the same room, 97 out of 100 of those people would perform better on memory tasks than I could. So relative to my peers, I have a lot more difficulty with memory information. And so we're looking for 3 areas scored at the 3 brain domains that are impaired at the 3rd percentile or lower to meet the minimal diagnostic criteria for FASD. Now, sometimes you're going to see a report, and on the very surface of it, it looks like this child would meet criteria for FASD. But what we don't do in a vacuum. We do consider other factors, and particularly early childhood experiences. So early adversity, trauma, and loss. And a lot of the children that we assess are not with their original families and have been in care and have had multiple foster placements, which are traumatic in and of themselves. And so early trauma is one of the most common things that we will consider when we're looking at our scores, particularly if they haven't had any period of stability. And so if they're still in a loop of, numerous foster placements. And so if we see some low scores, but we see some high scores, and the child hasn't had a lot of stability, we would likely be inclined to provide an at-risk designation and reassess them in a few years' time, because what we've seen is that the children that have experienced early trauma and have periods of stability, their scores improve. And so we want to know, is this an environmental thing that we're looking at any given day, or is it really a brain-based score? And so we do factor in, particularly of all the things on this list, that early trauma piece. Other things that maybe confound that we factor in, exposure to multiple substances in utero, women who do have difficulty with alcohol abuse, may also be using or abusing other substances. Poor prenatal environment, disrupted home environment. Like I said, that frequent foster homes or frequent changes in foster homes. Poverty, early poverty and lack of stimulation, that neglect or abuse, and ongoing parental substance abuse. So these are all of the things we're factoring into this person as we're seeing them. Is it the brain, or is it the environment that's talking to us right now in our test results? And if we're unsure, then we're a very conservative diagnostic team, and we err on the side of caution, and we will bring them back in a few years' time to reassess them. I'm not an interventionist, but I just left this slide in here. So, what is an interventional model that is recommended for FASD? And that's a neurobehavioral model of intervention created by Diane Malbin. And she understands, like we do, that FASD is a brain-based disability. It's actually a physical disability with learning or behavioral symptoms, okay? And if you attempt to change these superficial symptoms, the behavior, without understanding that it's a brain-based disability that's causing the behavior, then your intervention is not going to be helpful, and in fact, it may cause harm to that individual. And so we need to apply a different way of thinking when we're dealing with children and individuals with FASD. We need to apply what I call cognitive restructuring, not to the child, but to ourselves. We need to take a step back and say, what I'm seeing is because this child is processing information differently, because their brain is processing information differently. And we need to start to employ reasonable accommodations using the behaviors cues to understand what we're looking at and to improve their outcomes. So we need to modify that child's environment. We don't ask the child to modify them to our environment. We modify the environment to fit that child and that child's needs. And as an outcome of our assessment, we're going to have those needs identified in the assessment, and we're going to have recommendations specific to that child in our reports. And so it's very important to read that report, to share that report with the school, to share that report with community partners that are working with the child, so that they can design specific interventions, environmental accommodations for that child. And that's what we do here. And if there's any questions, I'd be happy to answer them. If not, give the floor over to Maureen.
Thanks, Kelly. Does anybody have any questions? If you have questions, you can put them in the chat box or just go ahead and unmute yourself and ask. If not, we will take a short break before Marie comes on. But I'll give you guys another couple of minutes for any questions. So we have some people connecting. Sweet. Well, that's great. Well, if you think of some questions later on, you're always welcome to email me, and I can get together with our team and see if we can best answer them. And if you have any questions for Kelly, you're welcome to email me, and I can forward them to her, or just email her directly.
Thanks, Kim.
Yeah, no problem. Fran, is she hopping on right at 11? Do you know?
Maureen, are you on right now? I see that you're...
Yeah, no, I am on.
I'm just going to stop sharing then.
Okay. So we're going to just take about a 5-minute break while our next presenter comes on board when she gets organized. So that works for everybody. And we'll switch over to Maureen.
You could just pause the recording.
Great idea, Fran. Let's start. So our next presenter is Maureen Parks, and she's the FASD coordinator for Norwest Community Health Center, and she's going to give us a little presentation. Now, if you haven't changed your name, it's helpful for us to just know who we're on the call for. So if you're able to just change your name to on the Zoom to your actual name, that's helpful. If you're not comfortable with that, that's totally fine too. And just once again, just a reminder that this is not a confidential platform. We'd love it to be, but it's not. So if we're talking about anybody in Pacific, please make sure you're not using names or any descriptors. And then we always ask for respect and, you know, try to keep everything private as much as possible. But I just want people to make sure people are aware that Zoom can be hacked. And yeah, and Maureen, go ahead. If you need anything, let us know. I'm going to go ahead and mute myself and others, and she can take it away.
Okay, thank you, Kim. Thank you, thank you. And thank you, Kim and Fran, for the opportunity to be here today and join you, and for providing me a little bit of time to give you this presentation. So as Kim said, my name is Maureen. I work at the Norwest Community Health Centers, and we've been running a program for approximately, a program dedicated to the needs of individuals with an FASD or suspected FASD for about 17, 18 years. So we've been around for a while, and you know, one of our primary programs here at Norwest is our diagnostic clinic, but we've grown quite a bit over the years as well. So I'm just gonna, you know, there's gonna be a little bit of information about that. Also, Kelly, the presentation I had the opportunity to watch was excellent. It was just excellent. Thank you. Part of my presentation is going to like kind of skim over some of the things you talked about, but very, very little. So it'll be more, I'll be going more into our diagnostic clinic after the first few slides. So FASD, also welcome everybody who's attending today. Thank you for being here. So fetal alcohol spectrum disorder, FASD, is a diagnostic term used to describe impacts on the brain and body of individuals prenatally exposed to alcohol. It is a lifelong disability, as you all know. And this is the new definition that we've adopted that was recently basically it was rewritten by CAN FASD. So we've adopted this definition as well. Individuals with FASD will experience some degree of challenges in their daily living, will need support with motor skills, physical health, learning, memory, attention, communication, emotional regulation, and social skills to reach their full potential. Each individual with FASD is unique and has areas of both strengths and challenges. And I know that over the years, you know, we've spent so much time learning about the challenges and the difficulties of individuals with FASD. So we do try to focus our programs on the strengths of individuals with FASD. And now when we open up a clinic and we see clients, the first thing the doctors will talk about are the strengths of the people that they're seeing, based on what we found in their neuropsychological assessment and consults and conversations. So I know Kelly touched on this. How common is FASD? Well, recent studies are identifying a prevalence of between 2.4% and 4.8% in Western countries. So as high as 1 in 50 or as low as 1 in 20. Compared to other common disabilities, at an estimated prevalence of 4%, FASD is at least 5 times more common than autism spectrum disorder. And I know sometimes that raises some eyebrows. 19 times more common than cerebral palsy, 28 times more common than Down syndrome, and 40 times more common than Tourette's syndrome. Now at a conservative 2%, 40,000 students with potential FASD may be in the Ontario school system. And it's estimated that 60% of individuals 12 years and older have had disrupted school experiences. And I know that through our experiences with working with FASD, this is one of the things this is actually quite common, right? That comes up in our conversations and in our questions and consults and when we're doing assessments, the last grade that this individual might have completed, and the most common answer is grade 10. And obviously we know finishing school is really important, and this isn't about the individual not being smart, it's about that the learning environment isn't conducive to their type of learning. It's estimated that about 80% of adults with an FASD are in dependent living situations. And with that information, we realized that we have to provide support to, the support with daily living, activities of daily living is very important. Approximately 80% of adults with an FASD will not be gainfully employed. And I sure don't, when I even talk out loud and I hear my own words, I don't want this to have a depressing slant, but the fact remains that our individuals that we're identifying and diagnosing with an FASD are going to require extra support so that everybody can feel success at the end of the day. Juveniles with an FASD are 19 times more likely to be incarcerated than non-affected peers. And I know Kelly spoke to this, as many as 90% of individuals with an FASD have co-occurring mental health conditions. And the cost of FASD in Canada is about 6.2 billion annually. And this cost tends to change over time. So I know that Kelly identified one demographic of women who might be consuming alcohol through pregnancy, or at the beginning of the pregnancy. One of the things we hear as well is, why can't mothers just quit drinking when they find out they're pregnant, or why are women drinking when they're pregnant? And we are extremely non-judgmental. There can be no shame and no blame, and we could never do this work if we had that attitude. And so here's a profile, though. This is another demographic that we have to be concerned about. And here's a profile of 80 birth mothers of children with FAS, a profile of 80 birth mothers. Now, 96%, almost 100% had 1 to 10 mental health disorders. 59 had major depressive episodes, 22% manic episode bipolar disorder, 7% schizophrenia, and 77% post-traumatic stress disorder. 95% had been physically or sexually abused during their lifetime. 79% reported having a birth parent with an alcohol problem. So that raises also, when you hear that 79% of this profile of 80 birth mothers had a birth parent with an alcohol problem, that also raises the question, what is the chance, right? What is the chance the birth mothers also have FASD themselves? So this is also, or is there a possibility that they might have an FASD? And I know through our consults, and especially through our initial consult, when we have the opportunity to sit down with a birth parent, with a natural parent, which is in our world a wonderful thing, because these are the moms and dads we want to talk to. They have the information we need. And so sometimes when birth parents say, my son is exactly the way I used to be. I used to do the very same things my son used to do when I was that age. So right away that, you know, that raises the question, is there a chance that maybe mom and or dad has an FASD themselves? And so when we explore that question, when we think about that a little bit more and ask additional questions, we're finding that not only are the children being diagnosed with an FASD, but the parents move on to getting a diagnosis as well. Now, here's some other research that also found that women who gave birth to children with FASD are at increased risk for suicide attempts and completions. And this is likely a reflection of the social complexities faced by this group of women, as well as the high rates of mental disorders and high levels of alcohol consumption in this population. Factors that determine the level of damage, this is very brief. Amount of alcohol consumed and pattern of consumption. And Kelly spoke very well to the alcohol exposure history that we're looking for. When in the pregnancy, mom is drinking, and susceptibility of the individual fetus. There used to be lots of conversation about genetics versus, genetics. And what we know is alcohol causes the damage, and genetics basically determines the extent of the damage. Mom's tolerance for alcohol, size and weight of mom, general health, nutritional state of mom, which is very, very important to the health of the baby, age of mom, maternal metabolism, use of other drugs, including tobacco, and now we're going to add to that marijuana. So, sorry guys, and the impact on the brain. We know the brain is the first and last organ to be impacted. We know that the brain is the only organ system developing throughout the pregnancy and is therefore the only organ that can be affected by alcohol exposure at any point in pregnancy. So if mom doesn't use alcohol for the first 6 months, but uses it for the last 3 months of pregnancy, there can still be impact on the brain and damage. In this study, alcohol consumption in 321 pregnant women, when self-selecting drinks, their estimated drink size was up to 307% greater than standard measures. And the reason when this slide always makes me think, there are some medical professionals out there, and no disrespect to the medical profession, but we do still hear today, as we sit here today, we still have people say to us, well, my doctor said if I'm feeling stressed out or I need to relax, it's okay if I have a drink. I can have a drink of wine, or maybe I can have a beer. So the question is, what is the definition of one's drink? And so it always makes me think of that when I read this slide, that the definition of a drink is different for everybody. And that's, that's the kind of information you need when one is giving that advice. So we know there's no known safe level of alcohol to drink when you're pregnant, and binge drinking and heavy drinking, as Kelly also was talking about, have the strongest link with FASD. We know that lower levels of alcohol use may be linked with low birth weight, preterm labor, isolated birth defects, or learning problems, and drinking levels may be underreported. I think one of the hardest things is for a mom to disclose that information. Did she drink alcohol during pregnancy, and how much did she drink? We know hands down that many women do drink before they know they're pregnant. And for some of the reasons we went over, if mom has a significant substance use disorder, she's going to need some help. She's going to need some help to cut down on her use during pregnancy, and it's not always there for her. the help isn't always readily available. So now let's just talk diagnosis. So in our clinic, so here, I'll go there. So at the Northwest Community Health Center, we are a primary care model. We serve people who have a higher risk of poor health, or people who are having difficulty finding health care because of language, cultural barriers, poverty, or isolation. We consider the social, emotional, financial needs of our clients, since these factors affect a person's health. Now, the Northwest Community Health Center has family physicians, nurses, nurse practitioners, counselors, dietitians, nutrition workers, community health workers, harm reduction team, overdose prevention team, and the RAM team, which is the Rapid Access Addiction Medicine, which is relatively new. And we have a lot of support staff within our center. We are one of 75 community health centers in the province and have been providing healthcare in Thunder Bay for well over 25 years. We're funded through the Northwest Local Health Integration Network, Northwest LIN, and we provide primary health care to approximately 14,000 clients at 3 sites in the district of Thunder Bay. We have a site in Thunder Bay, in Long Lac, and in Armstrong. Now, specifically, we're the only community health center in Ontario that has a program dedicated to meeting the needs of individuals with or suspected to have FASD. We follow the Fetal Alcohol Spectrum Disorder Canadian guidelines for diagnosis across the lifespan. Referral for diagnosis can come from any source. It does not have to be a medical referral. It could be a self-referral, family referral, any referral, and it can be done by phone, email, or request form. We hold diagnostic clinics once a month, and we provide assessments for all ages, so across the lifespan. The oldest we've done assessments for have been for people in their early 60s, which was quite amazing. So our team includes doctors, nurse practitioners, and neuropsychologists. Now the neuropsychology, that is the only fee for service that we have. That is not part of the community health center. We don't have psychologists here at this point. So that's the one fee that, but we work with every individual and try to access services that will provide funding for that service. The FASD coordinator, myself, we have now a part-time FASD community health worker. We now, relatively new, we have a speech and language pathologist on our team, brand new occupational therapist, and outreach workers. And we'll refer to other specialists in the community for other services. So the outreach workers are really important to us because sometimes when we've started an assessment on someone and then they go missing, or they go MIA, our outreach workers actually work really hard at finding people for us, finding our clients. So basically what happens is when a referral is made, people come in for a consultation, but we also use telehealth. So for people who are east of us, like Sault Ste. Marie, or Sudbury, we can do our initial consult over telehealth and now over Zoom. We're finding Zoom is really convenient. And so we do the initial interviews, consultations with clients in Northern and Eastern Ontario with myself, and we can do it via telehealth or Zoom. Now, the only problem, obviously, with people who are outside of our district is travel. Now, although we do not provide funding for travel, but we've been having relative success, and I think, Fran, you can speak to this, a relative success with getting travel assistance through, of course, now I forget the name, it's non-insured, sorry, through non-insured services. And, or in other cases, we've had people going through the Northern Travel Grant. They come into the community, our community of Thunder Bay, and what we do is I'll organize all the appointments at once. So when they come in, we do another consult after the initial. They will come in as well while they're in our setting in our community health center. We'll do the medical intake, including the measures. Then they spend a day doing the neuropsych, go home, and then we finish the process over telehealth or Zoom. So they can actually attend the clinic, the final piece, the FASD diagnostic clinic, this way, virtually. So the other thing we run into is people will say, well, why diagnose? What's the benefits of a diagnosis? Why? And the other thing we have, excuse me, is we have people referring to FASD as a label. And I really do struggle with that because it's not a label. It's in fact a medical diagnosis. It's a medical issue. And we know that diagnosis is necessary to helping us promote understanding of the person, put a plan in place to help the person throughout their lifetime, help us examine to others, explain to others what the needs of the individual impacted with FASD are in order to gain their help and support, and help us in getting supports and services. And the one thing that's not on here, because this is actually also a training slide, is that one of the greatest benefits for diagnosis is for the person themselves. The person who's being assessed, they need to know if they have an FASD. And anybody working in the field of FASD will agree that diagnosis brings clarity, understanding, stability, structure to that person who has FASD. Some people are afraid, actually, and some people are afraid of what's going to happen if this person gets diagnosed. Are they going to be mad? Are they going to be really mad at their mother? We have yet to come across that in our services, and we've been doing this for a number of years. We find that our clients who are getting diagnosed are often, especially our adult clients, are often, they're not surprised. They kind of expected that to happen, and that it brings relief and it gives us a starting point, right? So, and that's the greatest thing. Then the next step is, okay, now what? How are we going to support this person? How can we help this person be the best person they can be and stop blaming themselves? Often seen in those with an FASD, language disorder or impairment, and impairment. That's a big one because many of our clients who are impacted or have been prenatally alcohol exposed often are very verbal and have very good expressive language skills, which hides the actual, which hides the possibility that they might have FASD or hides the fact that they should be referred for diagnosis. ADHD, reactive attachment disorder, which is often now referred to as developmental trauma. Kelly spoke to this well, and we've often said, at least in our practice here, that individuals with FASD are probably one of the most traumatized population. And so that brings a whole different set of support required at times, depending on the trauma. Conduct disorder, oppositional defiant disorder, developmental coordination disorder. Genetic disorder, intellectual disability, sensory integration disorder, which isn't necessarily required to, we don't necessarily look for that in the assessment piece, but we know it's there. And often I know here we're telling people that there needs to be a sensory integration assessment, right? And because that one can actually have huge impact on behaviors that we see with younger people, especially with potential or possible FASD, learning disability, organic tic disorder, post-traumatic stress disorder, and sleep disorder, which is extremely common with individuals with an FASD. I do believe, and I don't have my notes right on this one in front of me, but at least 75% of individuals who are prenatally alcohol exposed are going to have some form of a sleep disorder. And this one has to be, there has to be consideration and in this piece. And because if you have a child who's not sleeping well, then that's actually going to impact, it's going to impact behavior and schooling and life in general, right? So you're going to have a sleep-deprived individual with potential brain damage. Often seen also includes the mental health disorders. For our clients in particular, it's unusual for a client to say that they've never had anxiety or depression. It seems to be almost inherent with alcohol exposure. Substance use disorders, autism spectrum disorders, brain injury, and medical disorders. Some possible misdiagnoses for individuals with an FASD, the ADHD, oppositional defiant disorder, and conduct disorder. So in our practice, we have to have partnerships. And this is also an area where we get referrals from. Children's Aid Society, Delico Anishinaabe Family Care, Children's Center Thunder Bay, who also now has Children's Center. They also deal with children's mental health. They also now have a FASD worker there. We also work with Confederation College, Northern Ontario School of Medicine. We work with both our school boards, addiction services, and so on. We work with a lot of services within Thunder Bay. It's interesting, it's unfortunate with COVID because normally we get the medical students come through our program, which we really like, but with COVID, so many things have been put on hold, including some of the programming that we're doing. We know we have to focus on prevention. We likely don't do enough of it. But one of the things we do is, as a primary care model, it allows us to provide on-site birth control to clients. Off-site programs also screen and offer birth control to all women. We have a lot of off-site programs. All women are screened for alcohol use or who are planning to become pregnant or at risk of becoming pregnant. So one of the things we do is with our young women, we are really, we're always encouraging them, making appointments for them, ensuring that they're getting their depot shots or they're taking their birth control or they're getting on birth control. Where else do we provide services? Well, we do screening and identification of at-risk clients at a variety of other programs and settings that are Norwest related. We have a mobile team that goes out to rural communities. They'll refer. We have a rapid access addiction medicine clinic, and which is, again, that's a relatively new one. We're getting a number of referrals through there. Our nurse practitioners work at a variety of locations in the city, such as youth corrections, homeless shelters, detox, and high-risk neighborhoods. And they're trained to identify possible clients and refer to the diagnostic clinic. So just when working with adults with an FASD, we just want you maybe to consider this developmental timeline in FASD. So here's an actual age of an individual, 18 years old, with the expressive language of a 20-year-old. And this is such a concern. And that's why our neuropsychs and our speech and language paths are so important, because they can identify that language deficit if it exists. Because again, their expressive language will throw you off. You won't suspect brain injury or brain damage when there's good expressive language, but you likely will see it in daily living. You may see it in behaviors, you may see it in schooling, you may see it in inability to work, maintain employment. So they have this individual has the reading ability of a 16-year-old. They can decode the words just fine, sound them out, say them, but the comprehension level of a 6-year-old, and that's of the spoken word and the written word. So you can see that there is going to be a problem when you're trying to work with individuals who don't necessarily understand what words mean. Physical maturity, even if they might be a bit smaller at birth, many of our clients are on par with their other peers, you know, by the age of 18. Their stature, their height, they're fine. Emotional maturity, that of a 6-year-old. Social skills of a 7-year-old. Money time concepts of an 8-year-old. Living skills, that of an 11-year-old. So the problem here, as you can see, is now we have an 18-year-old, let's say, with the money time concepts of an 8-year-old. By the time individuals are 18, we're expecting that they're going to be able to hold a job, go to school full-time, manage their money, save their money, pay some bills, right? And those expectations might not be appropriate for somebody who has been prenatally exposed. Emotional maturity, that of a 6-year-old. It's not unusual to see that many of our clients act younger than their age. And there's, as Diane Melvin actually refers to it, dysmaturity. And we see that one often. So here's some keys to success and management strategies. You know, this might be obvious, but you need to really care. There's a high burnout rate when you're working with those who have a FASD. I know with the work that we're doing here, we have so many extensions of people who provide support, and thank goodness for that, because no one person can do it alone. Everyone needs to be trained, because as I'm sure Kelly will agree, if people aren't on the same page, and if we don't communicate with each other, and we don't know what we're saying to our clients, somebody else might come in and give different information, which can be very confusing for someone who has an FASD. So everybody has to be on the same page, right? And everybody always has to be communicating. Ensure basic needs are being met. So we know here that if we have a client who's homeless, we really can't do any work with the person until they're housed. Or if they're having if they're involved with addictions or substance use issues, we know that that has to be addressed before we can get, you know, do other work. So we have to ensure mental health and physical health issues are being treated, and we identify strengths. So I want to go back. The other thing that I don't know if I mentioned, with our clients have been identified as a priority population. So when we have somebody who comes in for an assessment and we find out that they have no nurse practitioner or primary healthcare professional in their lives, we bring them on and we take on their primary health, because we know they need primary health. And within this setting, excuse me, we also have access to therapists. We have access to psychiatry as well if needed. And general, they'll have access to a doctor and nurse practitioner as well. But what we have to consider is, when possible, provide a structured environment that includes clear and predictable routines. And I know that, that might, we know that it has to be like that in the home, but we also know that has to be like that in other environments as well. When possible, continued guidance for individuals with FASD so they don't get into trouble or put themselves in dangerous situations. We have to do this all the time with our clients. Not only are parents doing it, or guardians, or foster parents, or adoptive parents, we also do the same thing with our clients. And we put out fires a lot, every day. Every day we're dealing with crisis, and we're trying to, you try and get in front of it, but it's just hard to do that sometimes. So move and walk, either with your clients or your kids. Move and walk. Remember that their level of mental and emotional functioning may often be at a lower level than the chronological age would suggest. So we tell people that all the time, to keep that one in mind. We offer simple directions and orders in brief, and orders in brief statements. We know that having a long conversation with our clients, and anybody working in the field will agree, parents will agree, that these long conversations often are ineffective. The other thing that we help a lot with are forms, applications, appointments, money, time management. We do this all the time. We try really hard to, with some of our more affected clients, and clients we come to know that are having money management difficulties, we really work hard with getting a public guardian for them, because that ensures their safety to some degree. We offer social skills support, mentorship, and we try and teach skills in the context in which the skill needs to be used, which isn't always easy. So sometimes we're providing grocery shopping assistance, laundry assistance. It depends. It depends. But the one thing we do work hard at is being an advocate, especially in the school system, the mental health system, the hospital. So being an advocate is the most important thing. A person alcohol exposed needs, they need an advocate. So I went through that. Wow, I went through that quickly. So that's my presentation.
Thank you, Maureen. Does anyone have any questions for her? You can put them in the chat box, or you can just go ahead and unmute yourself and ask. And I know if you're anything like me, I'll have a question in a couple days. I'll think, oh, I should have asked that. And if that happens, just go ahead and you can email myself, or you can email Fran or Roberta, or if you have Maureen's contacts right here, I'm sure she can accept any kind of questions. And even, a month from now, if all of a sudden you have questions, go ahead and send them. And sometimes it's great, when these kind of questions come up, and just go ahead and send emails, and we always try to respond. And if we don't know the answer, we have a great team. Oh, somebody's talking. Yes, that will, try to find the answer. Yes, that happens. It feels like a Monday today, but it's actually a Tuesday.
Sure.
Mm-hmm. Well, that's awesome. I think we're good to probably sign off now. Tomorrow we have a video coming out. Then the following day we have Alan with some of his videos, and then a question and answer. So I really hope everybody can keep attending all week or check out our videos. And I hope you guys have an awesome week, and I'll hear from everybody and see you again. Any other questions?
Thank you, Kim. Thank you, Maureen.
Thanks, guys.
Thank you.
Yes, thank you, Maureen, and thank you, Kelly, for doing your presentation for us today.
Yes, yeah.
Thank you.
Thanks, guys. Appreciate it.
Yeah, it was great. Thanks.
Mm-hmm. Do we know who the FASD people were that were trying to connect the whole time?
I'm not too sure. You could stop recording though.
Oh yes, great idea.
It's like, okay.
Oh, do we know what's going on for tomorrow's video?
Oh, it still says recording.